Hello, am I audible?
Yes, sir, you're audible. Good morning, sir. Afternoon,
Thank
sir.
you. Thank you. Good afternoon, Akash.
Good afternoon, everyone. We are waiting for more participants to join, so we'll wait for 5 more minutes and then we can start commence.
Namaste. Good afternoon to one and all. I'm Dr. Prachit, Associate Professor in the Department of Epidemiology in IMANS, Bengaluru, and we welcome you all to this seventh Mental Health Dialogues. Mental Health Dialogues, as you all know, is a webinar series on pertinent issues related to mental health under the National Mental Health Survey 2, which is supported by Government of India, Ministry of Health and Family Welfare, led by NIMHANS, along with various other collaborating institutes. So we are thankful to all of you for joining here. I can see that more than 80 participants are there, and I'm sure very soon we'll have many more. So thank you all. So we have many people from our extended NMHS family and people from outside as well. So nice to see the enthusiasm. So in today's series, that is Mental Health Dialogue 7, the focus is going to be on challenges in carrying out mental health surveys. So mental health surveys could get complex, and we need to hear from different people, different stakeholders, different perspectives, both from the public health point of view and from the mental health or psychiatry point of view. So we have eminent resource persons as well as people who are working in the field, the survey coordinators with us, who would be delivering short talks, and then we are going to have an insightful panel discussion. So I pass this on to Dr. Meenakshi and Dr. Akash Anand to take the proceedings forward.
Good afternoon, all. Welcome you all again to the seventh session of Mental Health Dialogue. So, as said, we will have first two talks from two experts from the fields of community medicine and psychiatry. This will be followed by experiences from the field as narrated by the survey coordinators of NMHS. And at the end, we'll have a very interesting panel discussion as well with three speakers from the fields of community medicine and mental health. So we'll commence this session with the first speaker for the day, Dr. Manoj V. Patki. We would like to introduce him. He is the HOD, Community Medicine from Zoram Medical College, Mizoram. He's a highly experienced medical professional with over 23 years of expertise in public health. And he also currently serves as the principal investigator for NMHS in the state of Mizoram. His expertise includes collaborations with major national and international organizations such as PHFI, UNICEF, and also strategic partnerships with various state governments across the country. He has also published numerous articles in renowned national and international journals. And in today's sessions, Dr. Patki will share his insights and expert guidance on conducting mental health surveys from the methodological perspective. Over to you, sir.
Thank you so much for inviting, firstly, to this seventh mental health dialogue. I am really humbled that NMHS has given us a platform not only to conduct the survey, not only for partnering, but also to share our thoughts and also share some of the practices. I am being working in Mizoram here for last 7 years, and this is a newly formed medical colleges. So in that perspective, this chance is very helpful for us also to learn and also to share some of our thoughts. So thank you so much. I'll just quickly share my thoughts on this. So we know that we have been, this is the time where I know, sir, I always remember Girish sir saying that this should have been a prime agenda. Yes. So defining a public health agenda for mental health in India, I hats off and congratulate Nimhans for taking this lead. And this is the second survey we all are involved into it. I think this is what the entire world is requiring, looking at the wars. We are at a war all the time. We are having differences where the economics are is at different level altogether. The degradation of the environment and everything, the toll is on the mental health. We know there is the mental health is very vital to us, because if you see the global burden of the mental health from the psychiatry perspective, or well said is neuropsychiatric disorders, from the disability, depression, common mental health disorders, and substance abuse and psychosis is at an increasing pace, which we are day to day facing. So importance of these disorders for public health as mental health disorders, where they are increasing the risk of both communicable as well as the non-communicable diseases, and contributing to the unintentional or intentional injury to the mankind. We know that many health conditions do increase the risk of mental disorders, get into the comorbidities, complicating health-seeking behavior, increasing the complexity of diagnosis, and even more complex is the treatment or management. And further to that, to add is the influencing the prognosis or the outcome of what treatment, what we are offering to them. So growing moment or momentum, I would say rather a momentum for a global mental health is required, with recognizing its importance and the need, which to including our health status measurement. So a patient coming to us seeking for any of the help for a health morbidity, we need to dwell into the mental health status of that individual so that a comprehensive answer or comprehensive healthcare solution can be offered. And we know that with this NMHS2, as this I've taken from our MOU or MOA, where the crux of the survey, we are looking at this three-prong agenda at the burden. One, the burden of the mental health problem with a nationally representative population. Each one of us who have joined today is a part of this and representing some population. Secondly, we all are understanding this project would look at the health seeking patterns for the mental health. And at the third point, identifying respective states, current status of the HR and the services provided by the services. With that preamble, I'm just a couple of slides on my challenges, what I face truly in the state of Mizoram or me as the department of on my team and the community medicine. This was the first bullet was a challenge for me, asking help from the state government to be on board because Nimans approached us. The first PAI actually was Dr. Swati Patki. She became the dean of the institute. Then I became HOD and I took the lead and coordinated with Girish sir and his team. So at the same time, parallelly, we were talking with the state government that this project is coming to the state of Mizoram, making them understand why do we need the survey, because they said, oh, we already have a mental health division, why we require a third eye? But their approval, the government of Mizoram's approval is needed. So when you are moving into the field, the first step what you have to do or what we have done is to make the state government understand why do we need it, why do we have to measure our health status in perspective of the mental health. The second ladder or second step we conquered is, yes, we do have a state mental health nodal officer. Please coordinate with him. So with due respect, we did coordinate his office, and then we are doing all sorts of things which you are going to do a survey. So why do we again need? But we explain the process of NMHS2, what are we going to gain? And we always said that you will be on board for any discussion every time, whether it is the selection of a project coordinator or the FDCs or the MHSA. At all steps, we need your handholding and to let us understand the process and move ahead. Having done that, then there was a third challenge which we had is to selection and selecting people for the project on board. So selecting, we had received around nearly 20 plus candidates for project coordinator, and it's a Herculean task, I say, that to get a good team member, because most of the community medicine departments, we all know those PIs who have logged in also, they know these days there are more than 40 plus national health programs running in, and the Ministry of Health is on war footing for all the sustainable development goal completion agenda. So the community medicine is involved in most of the time. So we need a good person, good project coordinator, which is a very challenging task for the selection committee. Then when we do that, it's the FDCs who are going to use your flag, not only the flag questionnaire, but getting into the village, understanding the study design and methodology, how the clusters are selected, what is a multi-stage sampling, why certain districts have been selected because of the multidimensional poverty index, why these districts and why these blocks and why these villages. How are we going to use the GPS coordinates to locate the village? From which household we are going to start the survey is all are vital, and to do that we need a good data collector and who is tech savvy to understand or add our data, valuable data from the tablet and tablet entry. Then came the stage of definitely planning where we can do training for the FDCs, including the project coordinator. Unfortunately, I could not come to the induction TOT training to the Bangalore. I had the psychiatry PI, Dr. Rajesh Rongpi, and the co-PI from my department, Dr. Vanlal Dusaki. So for me, it was, I did not go under TOT, but I sat throughout the 45 days of training with this FDCs and making them understand why for 45 days we are sitting with them and understanding the project and taking them through. At the same time, parallelly, task of translating the tool is again a challenge. Getting a validated translator who will do also back translate and piloting the flyer, and how much time is it taking for a particular patient with a psychiatric PI or psychiatric PI sitting in the psychiatric OPD, going identifying patient and then implementing fly is again a challenging. And when there is no disorder which is getting logged in, so how to still have ensure quality assurance, that is the very vital for the project during the piloting and validation exercises. Then move when this took actually for us selecting, onboarding, and doing training almost took 2.5, 3 months time. October, we started with actual survey. Before that, I had to call community medicine also needs to do in my state, had to do coordination with the director of health services cooperation, because we are moving into the field. And the field is with primary health centers, there are sub centers, there would be ANMs, ASHAs, and at the same time, some of the village NGOs who are very active in the villages in the clusters shortlisted or sampled. So all this chain of people from INM, ASHA, Village Panchayat people, PSCs, and the NGOs, we needed assurance from the Director of Health Services that we are moving to the field, that we need your assurance, and making them understand that why we are moving to the field. That is, community medicine was involved in that. Then good cooperation and coordination, definitely without the psychiatric PI understanding, going through each of the disorders in during the training as well as when implementing was very vital. And I'm very thankful for Dr. Rajesh Rongpi, my secretary PI then, that he and me went into the field along with the team to understand, and wherever the hurdles are there in the initial period, you need to handhold the team and understand how the question is going to flow, how the questions are going to come, what would be some of the challenges which family will ask you, why are you asking these questions. When after the piloting, you have to, as community medicine, because the psychiatry PI will be definitely involved in the clinical settings, but for moving, we have 5 districts shortlisted for us in the state of Mizoram. So, and it's a completely 100% hilly terrain with difficulties. So these mountains are different from the Sahyadri hills, they're different from the hills in Uttarakhand and Himachal. So difficult terrain, difficult road conditions. So you need to map. Sometimes you can see the village on the Google map, but the going to that particular village or the cluster, you need to take nearly 6 to 8 hours to reach their place. So coordinating that and coordinating with a good transport, because safety is very vital when you are moving into the field with this entire team of field data collectors and along with this project coordinator. We encountered challenges again. Of course, I'm also telling that how we can overcome this. Of course, so we did hire a travel agency which is a validated government approved, so that with a trusted agency, because in my team most of the field workers are only one boy and rest of the females are. So we need a secure environment where we are going into the field. The next challenge, of course, we are facing is this or we would face is validating this 5% independent resurvey and supervised visits by the co-visits by the field, the project coordinator and the PI. We need to re-interview 10% of the interviews which are taken. Initially, what happened is because the tablets came little late to us, we moved with the hard copies into the field. So syncing data and backup of hard copy data collection tool is very vital. So we did a good exercise that carrying at least 10 to 20% of the clusters data, we thought that we needed a backup of hard copy. So we took printouts of the fly questionnaires and moved into the field so that we are not stopped that okay, the syncing is not being done. So we need, when the team is coming back from the field visit, then they sync the data. Sometimes they enter the data which we have collected in hard copy. The next thing that community medicine is also involved in the lodging and boarding of the field team is very vital again. So we coordinate with the NGOs, we coordinate with the village panchayats, and we also coordinate some of the government establishments in different clusters so that safe lodging and boarding is ensured for the entire team, and so that their safety is as vital for the project, and data is also very vital. So we need to take care of them. The couple of challenges what we're feeling is, yes, we have yet to plan together with the state nodal office some of the thematic area studies we are working on it. And we started with a much rigor and vigor in the Northeast, but especially for Mizoram. But matching the data collection timeline is just overshooted for us in my team. And the last challenge is what I would like to share is this MHSA is sometimes the state government, when we ask them about their data about how many patients or how many suicides are done, so some ambiguity, some shyness is there from their end that why we need to disclose our data to. So there is some hiccup is there, but we'll overcome that challenge in the MHSA data collection also. So yeah, these are the challenges which I'm personally involved in facing and rectifying and getting and moving ahead with the solution. That's it from my end. Any questions so far? Hello. Hello.
We would ask the audience to put in the questions in the chat box. If anybody has any, we'll take it up at the end of both the talks from both the speakers.
Okay, thank you so much then. Shall I stop share?
Yes, sir. Yes, sir.
Yeah, thank you so much.
Thank you, sir, for that very insightful presentation. Thank you for highlighting the importance of measuring mental health disorders and also taking us through systematically through all the personal challenges you faced while conducting NMHS in the Northeastern terrain. Thank you so much, sir. We'll move over to Dr. Das' presentation. Dr. Akash will be introducing Dr. Das.
Good afternoon, everyone. We are honored to introduce Dr. Anindya Das, Professor and Head of the Department of Psychiatry at AIIMS Rishikesh and the Principal Investigator of National Mental Health Survey for the state of Uttarakhand. With over 16 years of teaching experience, he has made significant contributions to psychiatry, including research on mental health, addiction, and community psychiatry. Dr. Das has been recognized with prestigious awards and has also published extensively in national and international journals. He has also held key leadership roles in various mental health initiatives, serving as chairperson for IPS Suicide Helpline Task Force and convener of the IPS Preventive Psychiatry Task Force. His expertise in advancing mental health research makes him a distinguished speaker for today's session. Over to you, sir.
Yeah, my screen is visible?
Yes, sir, it is visible.
Yeah. Okay, then. Very good afternoon to all the participants who have joined. And thank you, team NMHS and NMHANS. So for today's talk, the challenges, particularly from a psychiatrist's point of view, was pointed out to me to be presented. But what I have done is uh, just the amount of work that we have done is generally okay, I would say, and various issues that I as and my co-PI have faced during the survey are things that I like to point out, and then we can take that as a experience of the microsphere, and then expand it to the general understanding how these challenges actually happen when there is a large survey going on. So at a team, as pointed out by my previous speaker, the team is an important instrument of survey. And generally, there is two or three things that are important. A team always, when there is a long period of survey, the team often changes and there is always attrition of staff. As a result, new recruitment means then there is additional work of training that staff so as to have a significant amount of expertise to conduct the interviews in a at a particular quality level of quality. And then when there is team, then there is also a conflict between members of the team. So as a supervisory personnel, it is important that we attend to those conflicts, resolve them, and then proceed forward proceed forward with maintaining the tempo of work that is going on. Then there are field related small nitty gritties. So the work of a field data collector and the arrangements of daily life is literally very difficult. You are actually a migratory population for the few months that you are uh, taking the data. So it is kind of shifting from one place to the other, and then finding out a proper stay, uh, a proper vehicle to transport you are important challenges that as a PI would have to take care of. And then you have interruptions when you are working in a team. Usually what happens is I'll point out that the best output would be when a cluster is completed in a day with the full team being in place. Once there is a member who is absent from the team and the cluster is far away from where you are based, it becomes difficult to revisit that cluster given the challenges of terrain, which some places will have, some places might not have. And these are important things, I think, that conducting a survey at the ground level are difficult. On the other hand, then there are other grand challenges. As a psychiatrist, I would say the interviews and the tool that is used to collect data to mark morbidity, because mental health issues have a difficulties in terms of what would I say, subjective nature of the complaints, and then to objectify through an assessment instrument, it's a big leap. So the validity of the instrument, how though it might be significantly noted in literature, but at the same time, the person who is using that tool, the expertise of that particular field data collector is a vital aspect which can change the overall output of the results of the study. So at the same time, planning the expenses at the general level, there are various contingencies that at the field level we face. So as a designer of the survey, it is important that these are forethought at the same time. Then there's some ethical issue that as a psychiatrist I faced, and this is an experience the last week. What happens in a far-flung area where you have detected morbidity, for example, and there is a service need, but there is no service available? How do you deal with that situation? How to negotiate with local authorities or health services so that the needs of that particular individual is met. So this is an ethical aspect that one has to face in the field. Then there is the aspect of certain questions which can be either the respondent might not answer in affirmative despite having those problems, or but at the same time there may be other challenges. For example, in one of our field data collector, a female field data collector had to ask about substance use, and the household head himself was intoxicated. So that becomes a very difficult situation at that point of time, and the I had to intervene in the sense that immediately asking the survey coordinator to intervene into that situation. And then there is the aspect of what value does our respondents take or keep in terms of responding to these surveys. This is because if one understands that this is an important task, it is often that the person gives more authentic answers. But at the same time, as an individual who is situated in a village level, often we would like to ask, if I place myself as a respondent, I would always ask, what would I get out of it? So I think surveys might as well be followed through with services. So if one starts seeing the results come through, uh, people become more responsible in terms of participating in this. I think I'll conclude with this only, and I'll just place hand over my.
Thank you, sir, for that enlightening presentation on important challenges on conducting mental health survey from a psychiatrist point of view. Challenges mentioned with respect to field operations, staff management, logistic hurdles are definitely important and need to be considered before start of any survey. I would request if any of the participants have questions for our speakers, kindly put them in the chat box. We'll wait for 2 minutes for any questions. If there are no questions, we can move ahead with the next session.
We'll move ahead with the next session. If the participants still do have questions, please put it in the chat box. We will take it to the speakers. So building on that, very insightful sessions by our experts, I believe we have a better understanding of conducting mental health surveys and the kind of challenges faced. To enrich our perspective on this, we are also joined by our very own NMHS survey coordinators from various states who will share the first-hand experiences from the field while conducting NMHS. First, we have Dr. Visalakshi, Survey Coordinator for Karnataka State, to share her experiences from the field. Over to you, Dr. Visalakshi.
Thank you, Meenakshi ma'am. Good afternoon, everyone. I am Dr. Visalakshi, the Survey Coordinator for Karnataka State. As of now, Karnataka State Field Team is currently conducting the National Mental Health Survey 2 in Kolar district. We have completed 23 rural clusters and 5 urban clusters. A total of 1,195 interviews have been conducted, of which 87, 870 adult interviews and 325 adolescent interviews have been done. As per our team's experience, we felt conducting a survey in a rural setting was comparatively less challenging than in the urban settings, as we had dedicated ashas in the rural setting who assisted us in mapping and introducing us to the community. This was one of the most crucial factor in rapport building with the community. One of the most persistent challenge we faced was stigma around the mental health illness. When we approached the households, the respondents often questioned us why their household was being selected when they have no such issues. So this entry level barrier was addressed by us by explaining them about the random selection process and also the importance of participating in the survey and how it is going to benefit them. Uh, Lack of privacy was one more significant challenge, particularly with the adolescents. Parents frequently insisted on being present during the interviews, which resulted in potential underreporting of the mental health issues. And also, some of the parents denied the consent altogether. They expressed their concerns that questions we asked regarding the substance use might give the ideas to their children regarding the substance use. And one of the most complex issue we faced was the respondents as expected to have an immediate treatment benefit, as Dasar just pointed out. Post the interview, they asked us what are the immediate treatment benefits they would be receiving. But at the same time, they didn't wanted it to be reported to their respective medical officers or the ASHAs. They feared community stigmatization if the ASHA gets to know, because most of the times the ASHAs don't understand the importance of confidentiality, which is accompanied with the mental health illness. The adaptive strategy we developed to address this particular challenge was we started providing information regarding the Telemanos project to the respondents. We gave them the number, we told them how to access the surveys, and we also told them about the availability of mental health services at the district hospitals. We told them about the district mental health program also. So I'm really grateful for this incredible opportunity where I could represent my state team and share some of the ground level challenges faced by our Karnataka state field team. Thank you, ma'am. I would like to.
Thank you, Dr. Vishalakshi. It is truly commendable that you have put efforts to navigate field-level challenges, especially around mental health stigma. Really appreciative efforts. Next, we have Mr. Tushar Bose, Survey Coordinator for the state of Bihar, to share his experience.
Uh, Hello, good evening, everyone. My name is Tushar Bose. I am survey coordinator from Bihar team. So we are currently working in Gaya district of Bihar, and so far we have completed 37 clusters, and we are currently working on our 38th cluster. So since the starting of our survey, we have got a pretty good response from the people of Bihar, and the response that we have got so far is much better than we expected. And when we tell them about the outcomes of this survey, so some people also encourage others to participate. But some people also ask, like, what are we going to get out of this survey? Like Dr. Anind sir pointed out. So we tell them that you are not personally going to get anything out of it, but the whole community, your whole village might get benefited from this survey for in the future. And whenever we face any sort of issues, we get active support from our central team as well as from our state team. Now, talking about the challenges, the biggest challenge that we face is the lack of awareness and the stigma associated with mental health. So, in field, people are very less aware about what the mental health problems are. So, when we visit any village, when we visit any cluster, we tell them that we are here for a mental health survey. So, they start complaining about their problems related to their physical health. Like they start complaining about that we have pain in our knees, we have pain in our joints, we have fever, please give us medicines. So we tell them that we are not here for your physical health illnesses. We tell them that we are here for a mental health we are here for mental health assessment. So in order to tackle this challenge, what we do that whenever we visit a cluster, so the first thing that we do is we like organize like 10, 15, 20 peoples from that village, and we give a short speech regarding what mental health problems actually are. So we tell them that mental health is not just limited to like what you see. Like w- they think that mental health problems are only that like when someone is behaving oddly, like their behavior is not like according to the norms. So so what we do is we sensitize them with what mental health actually is. We tell them that if someone is feeling sad for a very long period of time, that is also mental health. If someone is feeling stressed for a very long period of time, that is also a problem related to mental health. And if someone is in influence of some substance, that is also mental health. So this is one practice that we do at the beginning of survey in order to desensitize people uh, regarding the mental health. So I would like to thank for letting me speak, and that's all from my side. Thank you.
Thank you so much, Mr. Tushar, for sharing your experience. It's great to hear that despite all the stigma involved, your community have been so supportive and cooperative with conducting the survey. It's even encouraging to hear that from your side. Please keep up the good work. Next, we have Miss Ruby Kalai to share her experiences.
Good evening to all. My name is Ruby Kalai, a state coordinator from Tripura. We are very grateful and pleased to be part of this survey and would also like to thank for giving me this opportunity to represent my state. Our state is a combination of both hilly mountains and green plain areas, but we still have our own challenges. As a state consisting of both tribal and non-tribal, we faced a few conflicts. What I'm going to share is my personal experience along with the FTCs. It was a unique experience for us. On the second day of our survey, during our second interview, a group of villagers began interrupting and expressing skepticism about the interview. They created disturbances, so we showed them all the necessary documents to address their concerns. After reviewing the papers, they left, but soon returned with around 10 more villagers. We felt frightened and unsafe, but we stood firm. We explained our situation again, presenting the permission letters from the village leaders. Initially reluctant, they eventually decided to leave after seeing our determinations. After that, we immediately notified the situations to our PI and instructed us to leave that cluster as soon as possible. After that situation, it was immediately brought to the notice to Ashish, the state coordinator from the central team in Hans. It was clearly instructed that safety of FTCs as our top priority and made sure that especially no female FTCs would be sent alone for the interview. From these incidents, we learned to be more cautious, assess the safety of the locations for the team, and raise awareness with the help of ASHAs or village representatives before starting the survey. We are very thankful that with the shared efforts of FTCs, coordinations of both the survey coordinators with team, our PIs of Tripura and the central team of Nimhans, we were able to carry this survey smoothly. Thank you.
Thank you, Ms. Ruby Kalai, for that experience. It is very important to ensure the safety of your team. And as you rightly mentioned, we are also ensuring the safety of your team is the most important for not just for your state and NIMHANS as well. Next, we have Ms. Tausif Rashi, Survey Coordinator for Jammu and Kashmir, to share her experience.
Good afternoon, everyone. I am Tausif Rashid, Survey Coordinator representing Enhance Jammu and Kashmir. I would like to extend my sincere gratitude to the central team for providing this platform to share our experiences and fieldwork challenges. This survey is a landmark research study for Jammu and Kashmir, offering critical insights into the ground realities of mental health in the region of Jammu and Kashmir. Jammu and Kashmir has a unique socio-political landscape and a distinct topography. So our field work represents both opportunities as well as the challenges. So far, we have successfully completed 28 rural clusters, 9 in Ganderbal, that is the Kashmir province part of J&K, and 19 in Udhampur, that is the Jammu part of J&K. However, the challenges varied significantly between the two regions. As of now, we have completed 1,650 completed interviews. In Kashmir region, the population was very cooperative in conducting the survey, and it was very easy for us to collect data. While as in Udhampur, the challenges they were much pronounced because there was low mental health awareness, and we also the team also faced a regional bias as well as religious bias. There was language barrier at the same time because the population we were catering that was the tribal population, and they did not speak the proper Urdu or the Hindi language. So that was one of the challenges as well. And one more thing what we found that the facilities for mental health facilities, they were very far from the places which were our selected clusters. And to address and how did we overcome these challenges, we actively engaged various stakeholders, like we engaged village heads, religious heads, ASHA workers. At the same time, there were some areas we have to produce a document from DSP, from the police, that this survey is very authentic and it's a national-wide survey and all. That was also shown to the people or the the various stakeholders. And one more challenge which we faced was that there was a lot of inaccessibility, geographical inaccessibility in various clusters of Udhampur. They had difficult, tough terrains and poor road connectivity. At the same time, the population in these clusters, they were migratory. They were not living there. Their houses were completely scattered, but due to the winter, they had to migrate to the lower ranges. And we discussed this challenge with the central team, and luckily the central team provided us some alternative backup clusters, which we then catered. Beyond the data collection, our team took the opportunity to raise mental health awareness in these communities, and it also talked about some of the basic mental health concerns, coping strategies, and the available resources. Especially our team shared a Telemanas contact number where individuals in need could access professional mental health assistance remotely. They don't have to go to the particular place. It's not accessible, like, because in Udhampur, the main place where they could get mental health help was the Udhampur Government Medical College. And other than that, we provided the Telemanas number to them for assistance. And I believe this study is a crucial step towards understanding and addressing mental health issues in Jammu and Kashmir. I look forward to further discussions and collaborations to strengthen the mental health research and intervention in J&K. This is all from my side. Thank you.
Thank you, Ms. Tausif Rashid, for sharing your experience and challenges faced during the data collection procedure. Your dedication to not just collect the data, but also to spread awareness regarding mental health issues is truly appreciated.
We have a question from the audience to our speakers. It is asked, taking consent from the responsible respondent in the communities, especially if it's anything related to mental health, how to make the participants agree for the same. We would like to have the opinion of both our speakers on this question.
Can you repeat the question, please?
Taking consent from the responsible respondent in the community is tough, especially if it's something related to mental health. How to make the participants agree for the same?
Right. Okay. Yes, no doubt. It is not uniformly difficult with everyone, but yes, there are certain challenges. Those who are ignorant about mental health might as well give consent very readily. Sometimes, those who are too informed also might give consent very readily. What lies Where lies the difficulty is people who are in between, who have partial knowledge, some stigma, and some misunderstanding. Probably empathetic communication would be the answer to solving this problem. Partly information sharing, partly listening to them actively. All these might as well help to get the consent a bit more easily. But yes, but still it will remain a challenge. There will be a certain group of people who will not consent, and one should be um, at peace with it as well. So it is not a challenge to compel somebody to respond. I think as a team who is out in the field might as well take that as one of the outcome of of doing surveys. So my take would be like that. Okay.
Thank you, sir. Thank you for explaining about the spectrum of participants that people encountered while taking surveys. It was interesting to know that. We would like to have Dr. Manoj sir's answer to this question as well. Over to you, Dr. Manoj. I believe Dr. Manoj sir has network issues. In that case, we'll move over to the next session.
So after that, a wonderful session with the survey coordinators, we'll move on to the next session for today. That is a panel discussion. It will be moderated by Dr. Prachet R, Associate Professor, Department of Epidemiology, NIMHANS, and Dr. Lata K, Associate Professor, Department of Mental Health Education, NIMHANS. Over to the moderators.
Thank you, Dr. Akash and Dr. Meenakshi. So next up is the panel discussion on National Mental Health Survey, a team effort, and we have three distinguished panelists with us. Firstly, let me introduce you to Dr. S.M. Swami, so who's an esteemed psychiatrist with MBBS and MD in psychiatry, and he currently serves as the State Nodal Officer for the National Mental Health Program in Rajasthan. With over 12 years of experience in the government of Rajasthan, he has extensive experience and expertise in behavioral medicine, addiction psychiatry, and child and adolescent psychiatry. He is a member of the expert committee for the ICMR study on capacity building training for frontline health workers in screening and managing common mental disorders. He is actively involved in the ICMR multi-state implementation research on suicide risk reduction and improving mental well-being among students in schools and colleges. So he has a wealth of experience and expertise. This makes him a valuable panelist for today's session. Our second panelist is Dr. Satyanarayan S. So we are pleased to introduce him. He is an accomplished public health expert and an associate professor in the Department of Community and Family Medicine at AIIMS Mangalgiri, where he also serves as the in-charge registrar. So Dr. Satya has been actively involved in several significant research projects, including strengthening mental health and psychosocial counseling for frontline workers in the state of Andhra Pradesh during the COVID-19 pandemic response. He's also the PI for the NMHS2 for the state of Andhra. With over 30 research publications in esteemed journals, his expertise and contributions to public health research make him a distinguished speaker for today's session. And I've known Dr. Satya personally for more than a decade now. Our next panelist is Dr. Chetan B, who's my colleague and associate professor of psychiatry at NIMHANS Bengaluru. So with extensive academic and research contributions, He has guided multiple PhD, MD, and MSc nursing students and has over 50 publications in index journals, over 10 research projects, and extensive citations. So his expertise spans over various areas like community-based rehabilitation, forensic psychiatry, and telepsychiatry. So he has received several awards like the Young Fellowship Program at the World Congress of Psychiatry, and he holds key roles in the Indian Medical Association and Indian Psychiatric Society. He serves as the principal investigator for NMHS Karnataka from the Psychiatry Department and was also the co-investigator for NMHS Megacity and the NMHS 2. So we welcome all our panelists. So thank you for accepting our invite. So let us now begin this panel discussion. So my first question is to Dr. Satyanarayan. Dr. Satya, so if you could kindly let us know your thoughts about an effective and clear way to explain the purpose of a survey to the community members. So previously, one question was asked related to consent during the interaction. So if you could let us know how, what could be the correct way to explain the purpose of survey to the community members in a manner that addresses all their concerns and also encourages them to participate.
Thank you, Dr. Prachit. Good afternoon, all of you, esteemed speakers, my fellow panelists, and the delegates from all over the country. Thank you for NMHS team for permitting me to be a part of this mental health dialogue. So yeah, so the purpose of any survey, any survey will be successful only if we effectively communicate the purpose of the survey to the community. So for that, we have been doing data collection for the state of Andhra Pradesh for almost 3 months now. And from our experience, I would like to share some of my experience from this survey. So first and foremost is to appraise the local leaders who are there. So first and foremost is meeting these local leaders, Gram Panchayat members, and then appraise them that what we are going to do. Because more than that, we have permissions from the respective authorities that we will come to that in the later part of our discussion if time permits. But as far as in the community is concerned, we have to first make sure that we visit the local leaders and Gram Panchayat leaders, and we have to win their confidence in the survey. So I think that is one of the foremost thing which we usually miss, and then we learn from our experience that we have to do it. And the community survey questionnaire, which is a part of NMHS survey, I think that maybe NMHS team has done it consciously or not, but that is forming as a very good icebreaker. When we approach the leaders with this community questionnaire, and then by these questions, they get to know that why we are here and what we are going to do in their locality, and that we are not harmful. So that much is ensured by the community survey. So that is the foremost thing. That is what we experience. And then once you reach the households, of course, the ANM Ashas are important link between us and the community. So we will talk about the roles of ANMs and Ashas later, if time permits. So there again, within the family, we have to clearly define the survey's purpose. So what we are going to do and what is that we want from them. We are in a state in Andhra Pradesh, the data collection is very sensitive because few years back, some of the data which was collected was used politically, and based on their voting preferences, some of their names were deleted. So it is a very sensitive issue in the state of Andhra Pradesh as far as community level data collection is concerned, because even the general public is very much aware that if somebody collects my data and if there are chances that it might get misused. And being part of many welfare schemes also depends on these data. So they're very much worried that when you ask some of the personal questions like income and other things, they get very aggressive. So we have to be very clear that we are not going to ask any of those data, and we will ensure that this data which we are collecting is only for the purpose of the intended survey. And then, of course, in that process, ensuring confidentiality. We have to assure them this data will not be shared with the state authorities or to any authorities. So this will stay with us. So that is more important. After that, the impact of their participation, I feel. So anybody, they will ask this question, why should I be a part of this survey? So we have to present it in a way that they feel good about the survey. Being part of the survey is something good. We have to make them feel that the being part of the survey is good. Like we have to emphasize that this survey is being done all over the country. And then we are selecting few individuals from each state, So you tell them the bigger picture. You tell them that it is an all over this survey has been done all over the country. So by doing that, I think we can make them feel that, okay, what they are doing is contributing something to the country. So that is one way of handling participation, improve the participation. And then in case if they have any concerns, especially time, most of them, they will be the one of the disadvantage of the survey is a lengthy questionnaire. So we have to ensure them that we try to finish it as early as possible and the relevance of this survey. And then to do that, we use an effective tool. And fortunately, we have a very good tool, which is the tab mode of online mode of collecting data, which ensures that the survey is completed in a very fast sequence. So that is something, these are some of the things which we can do while approaching the community. And by doing this, I think we have fairly succeeded in getting participation from from the districts which we have surveyed. Over to you, Dr. Prachit.
Thank you, Dr. Satya. You've put forward many points like involving local leaders, clearly articulating the purpose of the survey once the team enters the household, and also communicating about the big picture, making it sound like it's quite positive, and ensure that the participation improves. So thank you for your insights. So moving to the next question, Dr. Chetan. So we often come across some sensitive questions and topics in mental health survey. So how does stigma surrounding mental health affect participation? Since we have questions related to various conditions like mental health conditions like mania or psychosis or epilepsy or suicidal ideation. So what strategies one can employ to encourage persons to participate in survey without the fear of being stigmatized?
Thank you, Dr. Prachit. At the outset, I would like to thank the NMHS central team for giving us this opportunity. So there are two types of patients who come. So one type of patients are the ones who already are diagnosed with mental illness and they are already on treatment. So generally, these people do not stigmatize mental illness because they themselves have gone through mental illness. The other kind of people who do not have mental illness are the ones who generally refuse to answer, or the ones who think that, okay, I might have a mental illness and if it comes out, then it will be a problem in the society. Those are the kind of people who will refuse to answer. The stigma plays a very large role in any mental health survey, not just in survey, even for the people who come to the hospitals. Like, for example, if they come to a general hospital, people would prefer to go to a general medicine setup or a neurologist rather than come to a psychiatrist. So stigma pervades everything. Now, when we go to the community and ask a few questions pertaining to their mental health, so it is important for us to tell people that mental illness is kind of any illness. Like, it's like, say, if somebody has a fever, or if somebody has appendicitis, or if somebody has any emergency, they wouldn't mind going to the doctor. Of the brain, and hence people who have mental illness can also come to a doctor. It's a treatable illness, which is very similar to any other physical illness. So once people get to know this, they will be forthcoming. See, how do we know that people are stigmatizing? So there are two kinds of people again. So one kind of people outrightly reject giving us any information. They tell that, okay, see, I don't want to disclose, I don't want to participate in this study at all. Here, where Dr. Satya was also telling about ANMs and ASHA workers, etc., connecting to local leaders and connecting to local people. And when they go and tell them that you need to participate in the study because of the larger interest, then that kind of stigma comes down. The second kind of people who kind of have stigma is that they ask us as to why should we tell. They do not outrightly refuse, but they ask us. So that's the easier kind of people we can handle. So there comes we should see it as an opportunity to educate people about mental illness. So, and when we educate people about mental illness, then the stigma in the community also reduces. And generally, people also, we also tend to tell people that mental illness is not something like what is shown in popular media. It is like any kind of an illness. And what we are asking, the confidentiality will remain. Once they get to know that, then probably they'll be more forthcoming in answering the questions. But we should also understand the sensitivity of asking certain questions, like, for example, suicidal tendency. We had a lot of difficulty when we introduced a suicide question in the NMHS Megacity survey. In NMHS 1, it was not there. So when we introduced that, when we asked people that, do you have ideas? The other people who were in the family would come and tell that you are actually, the person doesn't have any suicidal ideas, but by asking this, you're actually implementing this idea, or you're incorporating this idea into the person's mind. So we tended to tell people that no, it doesn't happen like that. When people openly talk about their suicidal ideas, their intent, etc., treatment can be given, and this can be prevented rather than it putting the idea in one's mind. So once people get to know what actually the mental illness means, what actually is the portrayal in popular media that they would have seen, which is not almost always accurate. There is dramatization. So when we give such data to them, then people will tend to answer as well. Thank you. Over to you.
Yeah, thank you, Dr. Chetan. So you spoke about several measures to destigmatize mental illness or mental issues. One could be normalizing it, but at the same time, we should understand the sensitive nature of certain questions, like, for example, suicidality. And let me also reiterate that one cannot force people to be a part of the survey. Yes, of course, we can convey the information in a better manner, articulate it in such a way that we can put a point forward, but after a point of time, the participant has every right to refuse, to withdraw as well, without giving any valid reason. So we need to respect the ethical principles for biomedical research while carrying out the survey. So thank you, Dr. Chetan, for your insights. So my next question is to our panelist, Dr. Savarmal Swami, sir. So, sir, certain states have legal bans with respect to alcohol. For example, Bihar has banned alcohol recently. So how can states effectively gather information about sensitive behaviors such as alcohol use from persons in such regions where legal factors may create some doubt or some fear to disclose such behaviors, sir?
Thank you, sir. And thank you, Girish, sir, and NMHS team. As we know that as mental health issues have social stigma, and due to the lack of awareness, it is very difficult to ask about mental symptoms, mental illness. And when we talk about the sensitive issues like substance abuse, alcohol use, and any other substance use, and also in asking about the suicidal ideations, it is very difficult to ask. But we should provide some strategic environment to the client, then he can reveal all things easily. First is privacy. Privacy is a very important part in interviewing. We should provide a private space, or we should provide a talk freely environment. And another is anonymity and confidentiality. We should ensure the client or the person that we are maintaining confidentiality and anonymity, that we are not raising your name in these details. And next is, third is rapport establishment. Rapport establishment is very important. Psychiatric illness or psychiatric survey interview is mental survey is not like just like any other survey. When we ask about diabetes, hypertension, we can directly ask questions, and people reply directly that I have these symptoms, I diagnosed, and I am taking these medicines for last 3 years, etc., etc. But psychiatry, it is very tough to reveal informations. People give biased answers, and they sometimes they give wrong answers. So rapport establishment is very important. Give time to the patient or person that can rapport. If rapport is well established, then we can ask any questions. After establishment of rapport, we can develop a trust, and as a healer, we should create a trust as a healer that with the help of some stories, we can tell some successful stories to that person that we are a healer. We are not judging you. And non-judgmental interviewing and active listening also a very important part of it. We are not deciding that what is wrong or what is right, but we are just providing a professional help, which in case of alcohol, alcohol is illegal, like in Bihar. Then we are not deciding or not talking about what is legal, what is illegal, what is right, what is wrong. We are non-judgmental. We are providing just a professional help, and we should create a trust as a healer is a very important part. And last is the indirect questioning. Indirect questioning is very important in sensitive issues. When we talk about suicidal ideation, then we when patients come in our OPD clinic also, then we don't directly ask that, do you have any suicide ideations? Do you want to harm to yourself? We generally we ask, mostly we ask a graded manner. We ask a simple question: do you have low mood? Do you have sadness of mood? Then we ask, do you have worthlessness? Do you have any? Then we ask, do you have any idea that life is not going well and life is not good? Then we ask, do you have any attempt? Yeah, any ideation, then attempt, and then we ask this is graded. Don't push on direct questions. Indirect questioning, parallel questionings are very important. Then when person becomes comfortable about that point, then he will reveal the information about his or herself. In case of alcohol, sometimes we can ask that what do you need when you feel low? So then person can themselves can reveal that I use alcohol or I use some other substance. Because directly when we ask that, do you use alcohol or smoke or any other opioid or tobacco, because some substances are socially accepted, some are not accepted, some are socially accepted but not legal. That points are very important in this criteria. So it is very important to maintain a confidentiality and a good rapport, and indirect questioning is very important in talking about the sensitive issues. Thank you.
Thank you, Dr. Swami, sir. So the key to handle such sensitive issues is to build rapport, give some time, gain the trust of the respondent, be non-judgmental, which is extremely crucial. And you also spoke about the art of indirect questioning in a gradual manner. I'm sure all our team members would have benefited from your expertise and knowledge, both as a psychiatrist and as a state nodal officer. Thank you, sir. So I request my colleague, Dr. Latha K, Associate Professor in the Department of Mental Health Education, to now take it forward for the next round. Over to you, Dr. Latha.
Thank you, Dr. Prachit. Welcome all the panelists for joining us today. So taking forward, I would like to propose the first question to Dr. Satyanarayana regarding involvement of ASHAs in this field survey, especially the mental health survey. what we have seen is ASHAs are acting as a positive catalyst in mental health survey. But still, there are concerns about potential breaches of confidentiality perceived by participants. And is there any way to balance this involvement of ASHAs during such surveys and also effectively maintaining participant privacy and trust?
Thank you, Dr. Lata, for the question. Yeah, so as we all know, the ASHAs are the most abused workforce in all of the country, especially at least from the health department is concerned. So we also feel at times, embarrassing to, ask help from the ASHAs again, owing to their already heavy workload. But what we found was, of course, involving ASHAs is the only way, because they are the ground level link between us and the community. So we have to involve them. But before going to the confidentiality part, we should understand how to involve them, because as I said, their workload is too heavy. So unless it comes officially that this is also part of their official work, they tend to not to get involved. So to ensure that, from our side, what we did, initially we started with getting approval from the state health commissioner itself. So with that, that is the starting point. So we need to have a permission from the state health commissioner or the principal secretary or health secretary, whoever is responsible. That is the first and foremost step. And then after getting that, we also make sure that we get a letter of approval and letter of permission from the respective district medical health officer, the DMHO. So with a written letter stating that these are the people who are going to come and this is what they are going to do. So we without getting the DMHO letter, we never go into the field. So once these two things checklists are done, and then our job becomes easy. So with these two letter of approvals, we approach the next level. We go to the PHC medical officers. So that is a third level. So we go them, we talk to the medical officer, and even before that, the district mental health team. Most of the districts do have the DMHP teams, though psychiatrists may not be there, but there are some staffs which are available in every district. So we involve them also. And then through them, we approach the ASHAs. And until now, the ASHAs have been very helpful. So they act as a bridge between us and the community. Another way of involving ASHAs is by giving incentives. So that is a very dicey issue. Though the project do have funds for as honorarium for field workers, but still we haven't explored that option. So because we didn't want to set a precedence. So without incentives, we have still been able to get the cooperation from the ASHAs fairly until now. Now, once these ASHAs get involved, and then they are the ones who take us to the community and introduce us. And as you know, being a mental health survey, so participants do have this apprehension that people are asking about mental health, and of course they will not see us again. But the ASHAs knows that okay, these families have been contacted for mental health survey. So the participants perceive that because of this, me or my family members might be perceived as having mental health issues. But then we present it in a way that it is only a screening. It is for general public to answer. We are not looking for illnesses. We are only screening all the population, irrespective of their social background or their medical illness. We screen everybody. So by assuring them first that to the ASHAs that we are not asking us the ASHAs to take you to mental health illness families, but take us to general public families. So that is drained into the ASHAs at the first level. And then when we go to the participants also, we make sure that we ask them, we make it clear that this is not a tool to diagnose any mental health illness. It is only to screen general public. Anybody can answer this question. Even I have answered this question. Even my friend has answered this question. So we are answering. So for the greater cause, we would request you also to be part of the survey. So by doing that, we have been fairly successful in getting cooperation from the participants. One other thing in the last round itself, I forgot to mention, incentives to participants. To motivate the participants, incentives goes a long way. But we don't have provision for that in our survey. But I was part of the LACIDAT survey where they do give incentive to the participants, and that the motivation was very good in LACIDAT survey. But here we do face little issues where the participants demand, what do we get after answering so many questions? What do we get? So that is why we involve the local PHC medical officers. So in case if anybody is particularly asking, then we request the ANMs and ASHAs to get some medicines with us. So at least if we distribute some essential medicines, so they are happy. Instead of leaving them empty-handed, at least if we give some essential medicines, they are happy. So that is a strategy which we have been doing. Yeah, that is pretty much from my side.
Thank you, Dr. Satyanarayan, for bringing in so much of your experiences, especially on the field and the different levels, how you have actually tried and involved ASHAs effectively, so that definitely your survey will be effective, and also to make your way easy into the community. So definitely, I think like once it is through official channel and once it is like through incentives, so definitely there are like evidences that the support and the compliance is very good. And also thank you for bringing in that point on like what the stakeholders, as stakeholders, even for the community members, so what they will be actually getting. So definitely I remember even as our postgraduates, or even when we have taken students for like long cases and other things, we have done like a free BP checkup, or getting some glucometer and testing, or giving some tablets. So that is like routine things, what is like usually like some of the practical challenges what we face in the community, and also what strategies at local level one is initiating. I think you have had a greater experience. And also one more point which was important was like that how the ASHAs are actually sensitized, that they need not only mention about the families with mental disorders, but it is actually for a screening. So that is also very important point. I think most of us should actually take up this initial stage when we are involving the field staff. So thank you very much, Dr. Satya. So I'll move on to Dr. Chetan for the next question on how do we address concerns of individuals, particularly adolescents? Because in NMHS 2, we have even adolescents involved as part of the survey. And most of them are also hesitant to sign the consent forms because of like either they are not aware, and or like they are scared about the potential consequences, or maybe even legal implications. And could you suggest what could be some measures to reassure and also ensure that they confidently give their informed consent, and also without causing any undue anxiety? So over to you, Dr. Chetan.
Thank you, Dr. Lata. I think it's very important. It's a very important question and a very tricky one to answer. Because as we know, adolescents are a tricky population, because for any medical or surgical procedure, 14 years is considered as that they can give independent consent, whereas they are not adults until 18 years of age for a lot of other legal aspects. So whatever they tell, can it be kept confidential from their own parents, who are the legal guardians? Because until they turn 18, legal guardians are still guardians, and after 14 they can actually give consent. So this leaves us with a very tricky situation, not just in NMHS but in all the aspects. Now, what should we do about this is the first question. The answer to this is that confidentiality here has to be maintained. There is no doubt about that. And we have to ensure, or we have to ensure telling the adolescents that we are not talking about a lot of high risk behaviors. We are talking about their mental health, and if there is any issue, bringing it to the notice if needed, bringing it to the notice of parents or anybody will only help them rather than harming them. So once they understand why this is being done, then they may go ahead and answer. But having said that, it is again tricky because of underreporting. Many adolescents, as Dr. Visalakshi was also telling, other participants were also telling here, that the adolescents are not allowed to give history in privacy. Many a times parents will be shadowing them, telling that, okay, it's our own children and we will be there. Because parents are also worried as to what type of questions will be asked to their children and whether they'll be carried away. So it's also important to tell the parents that they need to step out and we need to do this in private, so that we get accurate information of what is happening with the adolescent population. Even then, there is a very high chance of underreporting. There is no way that we will be able to handle this kind of underreporting if adolescents don't trust the system and hence they don't give us the accurate information. But at least how much ever possible that can be done with adolescents, we have to do that. Another way to do it is to ask sensitive questions in a very sensitive manner to all the adolescent children also, because there are questions on say habit, behavioral addiction, addictions, suicidality, body image issues, etc., anorexia, say for example, etc. So these might be very difficult for the adolescent to open up. So here, when we tell them that, okay, if they open up and if there is something, and help can be provided, so that the sense of non-belongingness for the adolescents can be actually dealt with, then probably adolescents will be trusting enough to give us the information. Regarding the consent procedure itself, it also happens many times that the children will tell that we will not sign. Many a times adults also tell that we will not sign, we will not allow our children to sign. Again, explaining the consent procedure to them and why consent is being taken, etc., will have to be done. Having said all these things we do, but even then, many a times the population may not actually agree to give us any information. As Dr. Prachit was telling earlier, we'll have to leave away that household and we'll have to move to the next household, and we'll have to take from adolescents who are willing to give information rather than persisting on adolescents who will not give the information. Thank you. Over to you, Dr.
Thank you, Dr. Chetan, for that very detailed and comprehensive answer. So definitely, it is very, very tricky and challenging in the field to interview adolescents and at the same time, to also ensure that they have the freedom to give their opinion or to share their experiences, because again, with the assent and even consent and also privacy issues being faced by the adolescents. So thank you very much for sharing your experiences in this. I could see some hands raised. So, sir, we will just finish the second round of questions with the panel, and then we will take the round of questions with the participants. So please keep your questions ready. You can share on the chat, or you can unmute and ask the questions. So I'll ask the last question to Dr. Sanvarmal Swami. As a program manager, could you please let us know what additional steps could be taken to ensure that we support individuals exhibiting symptoms of mental disorders and like those who are actually requiring medical attention, but unfortunately they are facing barriers due to lack of awareness or financial concerns or maybe even accessibility issues. So how do we ensure that as a surveyor, our moral responsibility is fulfilled and that they receive some adequate referral and necessary care and assistance without hampering the ethical considerations. So over to you, sir.
Thank you, ma'am. When a person is diagnosed as a mental illness, then it becomes a problem. He or she don't want to share this diagnosis to her wife or husband or any family members if he or she is suffering from neurosis, and it becomes problem how he can fight with the social stigma or lack of awareness about the mental issues. The first is awareness and psychoeducation is very important part to fight with this. Involvement of the community leaders, involvement of the public figures is a very important part. When Deepika Padukone says that I have depression in past, then every one thinks that it is a normal problem like diabetes, hypertension. So involvement of public figures is very important. And second is public awareness campaigns should be arranged by the government, or involvement of the non-government NGOs is very important part to create awareness and to reduce stigma in this perspective. Second is the financial problems when patient feels, then government should make policies like Rajasthan is providing free medicines under Mukhyamantri Nishulk Dawa Yojana and free investigations in the Mukhyamantri Nishulk Janch Yojana. So these policies can reduce the burden of financial burden on the patients. Because when patients become diagnosed as a schizophrenia or in a psychotic illness, then poverty also overlap to the persons, also troubles to the person. So financial support is a very important aspect for this, and the mental health medical insurance should be provided to the mentally ill person. It is also a very important or supporting aspect. Third is the collaboration with the local and remote resources. Proper referral system should be there. When a person in the rural area diagnosed as a psychiatric illness, the PSC medical officer should know about the referral system and what things he can manage at their level, and what level he should transfer referred patient to the higher or second or tertiary level. It is very important. And the tele-mental health services like Telemanas. Telemanas is also a very important a platform to resolve the problems. Patient can ask his or her questions or get emotional or psychological support from the Telemanas. Third is community outreach camps. Like district mental health programs, we are providing community outreach camps at PSC, CSCs, and other camps at the other places, that in this we can cover outreach patients. It is a very important, it is our right to provide mental health services, treatment and prevention to the public is our duty. Thank you.
Thank you, sir. So thank you very much for highlighting mainly on various aspects, especially on different measures to how we can actually ensure that referrals happen and at different levels. And also very importantly, mentioning about the tele support, that is the Telemanas, the initiative by the Ministry of Health and Family Welfare, Government of India, to actually call and ask for support, especially even the counseling services which are provided in various languages across the country, and also for mentioning about various camps through DMHP and the referral services. And also one more important like measure of insurance, like as already being highlighted mainly as part of the Mental Health Care Act, and also some strategies to reduce out-of-pocket expenditure, especially for mental health related treatment. And also to highlight about the important points related to initiate certain government related awareness campaigns or collaborating with NGOs and various other initiatives in order to reduce stigma, which is actually a barrier in help seeking, like maybe even for referral services. So thank you very much, sir, for sharing your experiences and also bringing in the necessary measures for how we can actually take it forward and also ensure that whoever is actually in need will actually get some kind of help, and we actually are able to facilitate that in a proper manner. So thank you very much. I can see Dr. Jairaj Singh Chauhan, sir. Sir, would you like to unmute and ask?
Good evening, everyone. Yes, ma'am,
Sir,
I have a
please.
question. Now, my question is that while we were in the field, there were instances wherein several respondents, they became there was an emotional unrest because of revisiting their traumatic memories, such as losing their relatives or some natural calamities of that sort. So, ma'am, can we not address those? Is there a way to address those, unsettled emotions because the respondents are not ready to approach any professionals per se?
Thank you, sir. Thank you very much for that question. So, Dr. Chetan, would you like to answer?
Yeah, see, it's a very important question that you have asked. So it does happen that not just about trauma, it can be about their own past mental illness also. When they're telling, there are tendencies that people will get emotional. So there are two ways to handle it. One way to handle it is that to listen to them calmly, give them some space, a non-judgmental, understanding space, and communicate with them about their distress. So even that kind of it will take longer time that day probably for the field worker, field data collector who is actually doing case for collection of that data. That day for that person, it may take sitting there and just listening to them will be helpful. That's one way to handle. Second way to handle is that for the first method, you should have some level of understanding about person's mental health. We should have some understanding about counseling strategies. If there are psychologists in the team, so the psychologist in the team can also be called in, and then they can actually help in there itself. That is not our mandate per se, but in times of distress, we can't leave the person high and dry. The second way is that then and there they can call 14416 Telemanas and then get help then and there at that given point of time itself. Because if the team of FDCs is not equipped to handle such kind of a situation, then help is always available. Help is available through Telemanas also. So that can be contacted.
Thank you, sir. I mean, I have completed my bachelor's and master's in psychology and a clinical trained psychologist. So I wasn't sure if we were allowed to, step in and start some sort of basic counseling. So thank you for clarifying it.
Yeah, it's like a basic psychological first aid. We are not
Yes, sir.
giving a session of 40 minutes there or 50 minutes. It's a courtesy basic first aid that we would do.
Oh, noted, sir. Thanks a lot.
It's similar to, say, for example, if a doctor has gone to a community or any trained person has gone to the community, a person falls with cardiac arrest, we'll not just walk away from there, that I have collected data and I will go. So we will still give resuscitation. So this is similar to that.
Yes, sir.
Thank you very much for that question, and also thank you, Dr. Chetan, for answering to that. So we have another question by Dr. Sumer. How can we explain to the respondents in simple terms why we are collecting their socio-demographic details? I would like to request Dr. Satyanarayan to answer.
Yeah, I think Dr. Satyanarayan had to leave.
Okay. So I'll just answer briefly, then I'll hand it over to Prachit to add on few points. So in any survey or in any study or the interview, we will usually have the initial discussion of like there are two aspects. One is actually to build rapport, like we need to actually know who they are and what is their background and all that information. And also later on, like for example, as part of the survey information, when we are actually collating, so it plays a very important role, the socio-demographic details, because that information will actually help us later to either in the final analysis or even to actually project like what is the status of the with respect to the economical status, employment, and various aspects, because there are various risk factors which can actually play a major role in certain development of certain disorders or chronic conditions, including mental health issues. So I would like to request the other panelists and Dr. Prachit to add.
Yeah, the key here is to build trust and rapport first, and then articulate to the respondent that privacy and confidentiality will be maintained, and this information will be used only for research purpose. Even then, some of them might be hesitant to share some of their details, especially income. It's already been pointed out in the talks as well. So this is one way in which we can try to elicit information, ensuring confidentiality, anonymity. So these are some steps in addition to what Dr. Nita mentioned.
Thank you, Prachit. So anybody else would like to pitch in? Okay, so we'll move on with next question by Luna Sangma from Meghalaya. So her question is, in majority of the clusters we have conducted surveys so far, element of privacy is missing. As not only the parents, but their neighbors and even villagers are involved during interviews. Responding by the family members, both adults, adolescents. Oftentimes, we are mocked by the villagers, and when politely asked to leave, they get offended and refuse to participate. So, how do you suggest in these situations? So, Dr. Sanwar, would you like to mention, comment on this question? Dr. Chetan? Because they are mentioning that most of the time there will be more active participation by neighbors and the other community members. So how to deal with?
Again, a good question. This is very common in when you go to a village. This is very common, especially when people from outside the village, people from city go to a village and start asking questions. People are generally curious and they come. So as you as the person who has the question also pointed out, politely telling them sometimes works, sometimes doesn't work. The next strategy is to ask the ASHA worker or somebody who is of that community to ask the people to give some privacy, telling them the importance of privacy and these things. So their own members telling them will make more sense. So that is where actually getting in touch with ASHA, ANMs or PHC medical officers or the Gram Panchayat members of that village will actually help. We can call them and tell that this is becoming very difficult. Can you please come and intervene? So when they tell the village people to go away, then they'll most likely they'll listen to them. The final thing that, although not advisable, final thing that can be done is to ask the respondents as to whether they mind. I have had, at least in one of the surveys, one of the person who was responding called all the villagers telling that, see, I am a very important person. So people from Bangalore have come and they're asking questions to me. So you also be there when they're asking questions. Many a times it may happen in that way also, although we explained to him that there is privacy is needed, etc., etc. Many a times this also can happen. So last resort, we can ask the person who is responding as to whether they mind. Many a times, to our surprise, people don't mind. Because they tell that everybody knows everything about everybody in the village. So there is nothing called as privacy here. So sometimes it makes me personally think that is privacy and confidentiality only first world problem, not a problem of rural communities. Having said that, confidentiality is very important. So we'll have to try to ensure that. So telling them politely, next involving ASHA or ANM or anybody from the community, and then asking the respondent themselves probably would solve the issue.
Good afternoon, sir. That was my question.
Dr. Prachit or Dr. Lata, do you have anything to add to this?
Yeah, I think she wants to say something, Miss Luna Sangma.
Yes, sir. Good afternoon, sir.
ahead.
That was my question. Sir, we do take the help of the Ashas and the Anganwadis, but sometimes it just so happens that they themselves, they have no concept about mental health or mental health disorders. And even we did ask for their assistance during in such instances, and she said that it was all right and that the person that we were interviewing wouldn't mind if there were people around, like Sir rightly said. Oftentimes they have no issues, but I feel like it is more of an issue for the adolescents, because the adults are very free and frank, but the adolescents are oftentimes shy because there is a mob surrounding them and that we're asking personal questions, because there are also questions about being touched and other personal questions. So I feel like that was a very important question that I needed to ask regarding that, because oftentimes girls that we are interviewing are victims of such things, but then they cannot open up. And once the interview is done, they come to us and they're like akka or sister, we have actually gone through this experience, but we were shy or we were hesitant to talk about this because the person who had assaulted them was right there in the amidst the crowd, and then she was very hesitant to talk about this. So how do you suggest we go about it, sir?
Yeah, thank you, Luna, for your question. Girish, sir, if we can see your hand is raised.
I think we can finish this question. But before that, I was just trying to look back at the issue raised in the earlier question. The whole village will be there. What to do about it? If it's not the whole village, at least the family members would be listening to it. I know that requires a little bit of tact by the FDCs, so that they're able to put more of the neutral questions which are more acceptable to them. And if possibly they see some flinching of the eyes or hesitation by the person who is answering, they can just skip that question and then possibly say, after they finish, would you like to come aside and then we can discuss about the issue what you raised, so that they have to use multiple strategies. It's not that they should immediately ask in front of them or not in front of them or ask them to get out. Many times that may not be possible, because as soon as you say that, the other members will start suspecting, and that could be a stigmatizing issue. The FDCs possibly that's where they need to look at the reaction of the individuals and then say that there may be an issue there, particularly domestic violence or related to trauma, PTSD. If there are some issues, they can just keep quiet and then come back later to that family and then say, this is what is an issue. That's the suggestion.
taking a pause and then coming back later. Yeah, that
Another
was, yeah.
another thing, particularly about this type of cases, is that as I was telling, generally it's the curiosity of people. That's why they stay there. So start with demography. Start with uh, don't look at the tab itself, or even if you're looking at the tab, don't ask the questions that are in the tab. Ask general questions to them, and once everybody knows that, okay, it'll take time, but once the other people get to know that, okay, these people are asking some usual questions, then after about 5 minutes or 10 minutes or so, then we can request them that, see, now most of it is over, but I need to talk to them in private. This is very essential for the study, and hence I would like you to step out of the room or take this person to another place and ask them. So most likely people will think that, okay, this is the same type of questions that will be asked, so they might not mind. Or coming back to the questions, or as Dr. Girish sir was mentioning, ask all the questions, come back to sensitive questions later.
Yes, so oftentimes we do conduct the interview as if we're having a conversation, and we oftentimes, since we are used to the questions now, we do look at the question, but we don't often look at the tablet. And when we are talking to them, also we make sure that everyone else also gets an understanding, because initially when we go, they're always very how do I say this? They're hesitant to participate. Therefore, we since there are a lot of people around, we make sure that we desensitize them about this whole situation, and we try to spread awareness as much as possible, sir, regarding that. And about skipping the question, sir, we do skip the question when we see that the person is, we can we can read the body language, and then we're like, okay, we'll move on. And then after that, like sir said, like sir has suggested, we did that many times. And but the only questions are the only query I have right now is, will it affect the interview? So because when we are once we are done with the fly, once we are done with the interviewing process, later when they come and tell us all that, we are not able to enter the data on the tablet. So can we add that in the remarks instead?
Yes. That would be great if you add it as a remark, or you share it with the central team. Weekly, we do have meetings, right? So share it with them. So in the back end, we can collect that data. Sometimes, and I don't think this will be too much. Statistically speaking, this will not be too many people who would have such a issue. So it will be here and there. So those things probably can be handled in the back end.
Okay, sir. Thank you so much.
Thank you very much, Dr. Girish sir and Dr. Chetan, for answering the question. And thank you, Ms. Luna, for raising those important points. If anybody else would like to unmute and ask any other questions, comments from any other participants? Okay, there are no more questions on the chat. Okay, I would like to thank all the panelists for joining us today for this panel discussion on the importance of various strategies and plans for managing various challenges of conducting this surveys in the field. So I would like to thank all the panelists for their insights. And also, I would like to hand over to Dr. Prachit for the vote of thanks.
Yeah, thank you, Dr. Lata. And first of all, I would like to thank our resource persons. So Dr. Manoj and Dr. Anindya Das and the survey coordinators who spoke today, and the distinguished panelists and the members of our team led by Dr. Girish, sir, and Dr. Shubhi, Dr. Meenakshi, Dr. Akash, Dr. Lata for moderating the panel discussion, and all of you for being a very active and engaging audience. So before we conclude, I request all of you to please turn on your videos so that we can have a quick photograph or a screenshot. Please turn on your videos, and I request one of our state coordinators from the NMHS central team to please click a photo of us. Yes, did we have a photograph?
Yes, sir.
Thank you, Dr. Shubhi. Yeah, thank you all for joining us. So we'll meet again next time with another insightful topic. Take care. Bye.
Thank you, sir.
Thank you.